Hi, everyone. I'm Rose Gerber, COA's Director of Patient Advocacy and Education. Thank you for joining us again today. And also thank you to all of you who joined our July Virtual Advocacy Summit. And I think that just deserves an extra thank you because that day was a very, very hot day, probably for everyone across the country, whether it was 9 a.m. in the morning or 12 o'clock Eastern time. So you were either sitting in a very cold air-conditioned office, or you were, just choosing to be part of that event with us instead of, escaping for the day. So thank you. And speaking of that day, I just want to give you a quick recap of the contents from that day, because a big part of our advocacy chats is providing you with resources to help you become a stronger leader, a stronger advocate, a more knowledgeable, independent person. So that day we had Dr. Lucio Gordon as one of our speakers from Florida Cancer Specialist, who was the president. FCS, I mentioned several times, is one of our largest cancer centers across the US. So to have him as part of our event was really a very big deal. We also had Dr. Agarwal and Dr. Atkins, who are CPAN medical co-chairs, practicing medical oncologists from Indiana and Georgia, open up the day and really talked about everything going on the front lines of oncology. We had our lobbying team, Jeff Mortier and Sarah Walters, who always do a terrific job helping us understand what goes on when you try to get a bill passed, some of COA's current hot topic issues. And one of the exciting things that Jeff really talked about too is bringing all of you with us, as many as we can anyway, when we get back on Capitol Hill. And we hope to be doing that live in 2022. So that was a great presentation. We also dug a little deep into some of the topics that are constantly an issue for us within COA and anyone in the community oncology community. We had expert speakers on PBMs and drug pricing. And Ted O'Connor was one of our speakers, who, of course, you all know is the executive director of COA and a policy expert. And our own communications team, which is headed by Nick Ferreros, Drew Lovejoy was also one of the speakers that day. They did a terrific job on how to use social media. So why this is so important is these resources are available on the website. And we did mention it during that day, but because we covered a lot, it's easy to forget. You should have got a reminder email that gives you access to those on-demand videos. And I've actually gone back and watched a few. And even though I was part of the live event, I learned a lot of new things from listening the second time. So again, that's a resource for you. So please just remember to take a look at the website. It's hard to believe, but we're going to be celebrating our 1-year anniversary with these advocacy chats, and I've just really, really enjoyed them. The only thing that I think that could make it even more perfect is if I could see all of you, and I hope to do that, live next year. But this is just a great way to engage and bring information. Today, we're doing something very different. Is we are starting to introduce you to different members of the oncology care team. And if you're on this chat today, obviously you know a lot about nurses or oncologists or reimbursement staff, but there's some of you who might think you know what nurses do, and maybe you don't know about the depth of what they do. And we're all going to learn a little bit about that today. So it is just my pleasure to introduce Brenda McGarr, who is a nurse practicing at Augusta Oncology. Brenda, welcome. And can you start us off by just giving us some background on how long you've been a nurse, where you've been a nurse, and kind of some of the roles that you have done as a nurse? Thank you.
Absolutely. Thank you so much, Rose, for having me today. I appreciate that. So I have been a nurse for 22 years now. So I started when I was 5. And I've spent about 17 to 18 years of that time in the oncology setting, both inpatient and outpatient. I've worked in Anderson, Indiana, Rome, Georgia, Brunswick, Georgia, and have landed in Augusta for the last 16 years or so. And again, inpatient and outpatient, infusion nurse, floor nurse, case manager for a number of years in the hospital setting, and then as a nurse navigator now, about 7 years in a hospital setting, and now for almost a year with Augusta Oncology.
Wow. So Brenda, you just mentioned a lot of different roles that you've had over your career, which is incredible. And the fact that you've worked in the hospital setting and you're now currently in the community oncology setting. I know that that's something that's very interesting for me too, is most cancer patients, myself included, when I was sitting in the chemo chair, my exposure to the nurse was literally just at that moment. I don't really understand what the nurse did, besides being this angel by my side, talking to me when I was down and distressed. And I know that so many cancer patients feel that way. It's well known about the relationship between nurses and patients. Mm-hmm. But there's a lot of different titles in the nursing industry, I should say. I did the little lab ears thing, which is weird. But there's, LPNs, RPNs, nurse navigators, infusion nurses. Talk to us about some of those roles and how they're different or how they're interrelated. What does it mean? I think I understand what an infusion nurse is because I've been a cancer patient. But yeah, just kind of expand upon those different roles, because kind of like we can't say there's one patient story, there's not one type of nurse. So help me understand that. Help us all understand that.
Absolutely. So I'm going to start with infusion nurses, since that's what you just were touching on and what your experience was as that cancer patient. And what you see is just a tiny piece of what they do. And I have so much respect for our infusion nurses. Just a shout out to Augusta Oncology, specifically to our nurses here. They do so many things. And I was in that role for a while, and I still highly respect what they do and feel like they've got the harder job even than I do as the navigator in that role. So what you saw was, like you said, at the chair side, but what you didn't see was the fact that they've already looked at your lab values before you get to that chair. They've already had a discussion with your physician that day. They usually come out and talk to you about you personally, any symptoms you've been having. They've read the physician's notes to know what's been going on with you and your family. And then in addition to what's going on at the chair side, they're communicating sometimes with your family whenever you're not feeling well. They're triaging phone calls all day as calls come in, and they decide whether or not people need to come in for labs and fluids. And then if they come in, they have to do the assessment, decide if they need fluids or not. They're pulling their medications sometimes for the treatments, depending on what drug we're using. They're doing, my goodness, they're doing prescriptions that need called in. They're doing prior authorizations for those prescriptions. They're setting up blood transfusions. I mean, the list goes on and on. That's just a piece of what they do. So what you see at the chair, you finish your treatment and usually the room is empty by 4:45 or 5 o'clock. They're there a lot of times till at least 6, just trying to catch up on what's been going on and who needs called, and did so-and-so get their Percocet called in time, all those things. So it goes way beyond what most people see. Sorry, I get a little passionate about that because I'm just so proud and thankful for our team. And I know that so many community oncology practices are similar to us in that role, that the nurses are really the backbone of what's going on in the practice.
Wow, that's just, really, that what you just shared is just incredible. So kind of let's dial that back a little bit, because that is really sounding like the most overwhelming to-do list.
Mm-hmm.
And when I say to-do list, I know that's probably not a term that most people associate with cancer care, but the reality is, you are handling so much. So is there like a nurses meeting in the morning where you go over like what patients you have for the day? Or is it just like you're walking, like for the oncologist, sometimes I think, did they actually look at my chart before they walk through the door? Help me understand, you gave us a lot, but let's dial it back even more.
Yeah, let's dial it back. So here at Augusta Oncology, we use a team nursing approach. So we have 2 nurses and a medical assistant and someone from the lab that all tries to work on the same team. So for example, Dr. Atkins, since she's so involved in a COA, she has a team. She has 2 nurses at each location where she practices. So if you're her patient, those nurses are going to know you. And that's what sets us apart too, I think, from the hospital setting of nursing or from the bigger practices is you're going to have those same nurses every time you come in the door. They're going to know your name, your husband's name, your dog's name. You're going to have that relationship. So they know about you already, but yes, they'll look a day ahead. They'll look at this afternoon, they'll look at tomorrow's list of infusions, see what's going on. Of course we have to wait on blood work till the day of, but they'll go ahead and look at what's been happening with you. Have you been sick recently? Have you called in recently for more nausea meds, and kind of get prepared for the day. Does that help clarify that?
Yeah, it really does. And by the way, I caught that dog reference comment, and listeners, pay attention to that, okay? That dog comment's going to play an important role a little bit later. So Brenda, so one of the things that, I'm going back again to my time, there's certain things that I have intentionally forced myself to forget. There's some things that I forgot, like they say, maybe part of patient trauma, but there's some scenes that I actually do very clearly remember. And I'm sure the cancer patients that are listening or the nurses also can recognize this. And every cancer center is different. But, oftentimes I'm thinking of the chemo bay, you go in and there's multiple chemo chairs. And at the cancer center where I was treated at, the nurses, I'll call it the nurses station, was in that room visible. And then there was some other rooms, like where the medication was stored. Can you kind of help me understand, like, where you have access, or, how much authority do you have? Like, I know that you work directly with the oncologist, But again, I think one of the concerns, or not concerns, a comment that I've heard over the years is, is the nurse doing what the doctor asked them to do, or are you telling the doctor what you should recommend? Help me understand that professional relationship between you as colleague and how that ultimately impacts the patient.
Absolutely. So it's definitely, again, I think the team nursing is the great approach here. It's definitely that communication with the physician. Yes, we're doing what the physician says to do. We're making the physician aware of, if Rose came in for treatment today and she says she's just been really extra tired and hasn't been eating and drinking well, that type of thing. We're not just going to go pop up your Taxol, get your day started. We're going to check back with the physician and let him know, if labs are questionable, we're going to run that by him first. I say we, again, speaking as the infusion nurses. So there is a constant communication and check with them. As far as the other rooms you're speaking of, we do have in our facilities have in-house pharmacies and a pharmacist that oversees that. So all of our medications are mixed in-house once we know you're okay and ready for treatment. So nothing is done or mixed until we've checked on your labs, we've checked with the physician, you're good to go for the day, we access your port or your PICC line or whatever you have, and then the drugs are mixed. So that's part of what's that going on behind the scenes. But in our particular facility, we have pharmacists and pharmacy techs that do most of that mixing for us, because that has to be done in a vented, hooded room with back airflow, and it's a hazard area. It's not accessible really to anyone but the pharmacy techs to be back in that area. The drugs are stored in a hazardous refrigerator, that type of thing. So there's a lot that goes into it that the public eye doesn't see.
You said two things again that, one triggered a memory is ports. I had a port. So I had a port for a very long time. And, I'm a long-term survivor now. So at that time, there wasn't the port pillows. That wasn't a thing. So every time I put my seatbelt on, it really hurt. It was, uncomfortable. Didn't you share something with port pillows recently where you give those to your patients?
Yeah, I can't remember when I first saw those, but I'm going to get a quick shout out to my cousin Bonnie in Washington State, who makes them for me.
She made those for you. You showed us.
Actually $40 a month, so that we have them for all 3 of our locations. And sorry, my computer just asked to reboot. No, that is not a good time for that. I stopped it. So they're just a little 4x4 square. You can actually go on, I think, YouTube now and find a video of how to make those. And just things like that are just a little personal touch for the patient to have. Like you said, so many patients will take that seatbelt and put it behind them because it's rubbing that area where the port is. So that's a way to keep you safer.
Yeah, and it was, going back to my time when I had a port and my seatbelt, it really bothered me, but I would just say, oh gosh, Rose, this is so minor. But I didn't know who to tell type thing. I just kind of dealt with that. But you mentioned also you were painting that scenario of the pharmacy and drugs as a nurse, because nurses, I guess it's kind of people just feel so comfortable with their nurse that they start asking all kinds of questions. Do you get asked about the cost of medication, or do people go to you with those type of questions, or what?
We do occasionally. We actually, with Augusta Oncology, we have patient account reps on staff that are not really nurses. They're not social workers, but they specialize in the drug cost and finding resources to cut back on the cost, find copay cards, all those types of things. So they are a huge part of our team in that respect. So as nurses, we don't really know or understand the finances of it. We know everything's expensive on some degree, but we kind of punt that off to them because they're the professionals for that.
So I have a challenging question for you, Brenda. I know that cancer patients, when they're dealing with cancer, it's so overwhelming, and you're just not your normal self. So I would imagine that not every patient that you care for has been easy to care for. So when you look back over your career, even for nurses now, was there ever any kind of training on how to deal with patients, how to deal with patients in distress, how to deal with difficult patients, overwhelmed patients? I've had incredible nurses. The majority of my nurses I've had, not just in oncology, but every cancer survivor knows, you have multiple doctors and specialists that you see over the years, and the majority of them have been incredible nurses. But I've also had some nurses that were very abrasive, and I just kind of internalized that, but it made me actually really, really sad when I've had those rare encounters, because you are so vulnerable. And I feel for the nurses, because I think the nurses get exhausted, because you're taking care of all patients, not all unpleasant. So what kind of training do you have, or do you have training? Is it just left to personality? I mean, what happens because I think that's a part of the job that people don't really think about. You just think about the nurse coming in and giving, checking the meds or giving the medicine. What training do you have, or do you?
As far as any specific training, I mean, that varies. You can always do like continuing education units to that degree. We do a lot just as far as supporting and helping each other here at the practice. I think we can tell when each other are getting tired or burnt out or might need a break. So I feel like we kind of keep each other in check on that. But as far as a specific training tool for that, other than what you learn in nursing school and then just ongoing education that you choose to pick up, is the main thing.
Right, because I do think that it's very, I would imagine that it's very different than other workplaces, because even if you love your job, and many of us are lucky enough to love our jobs, the reality is that sometimes, you get tired or something happens that disappoints you or makes you angry. But what's very different when you're in a role like a clinician or a teacher, that the way your behavior has such a dramatic impact on that patient or that student. So I've kind of always wondered about that. How that works. So one of the advantages that I would assume nurses that have worked as a nurse for many years is you have a broad view of nursing. Help me understand how nursing is the same or how it's changed from early in your career. Like when you're, how has it changed? What's different? What's the same? What would you change? What do you wish you could regain?
Wow. So like back in the old days, is that what you, no, I'm kidding. Um, I would say the thing that has changed to some degree is just the personal touch has been lost to some degree. Again, I mean, us in community practices, I feel like we still have that. Our doctors still know your name and still know your family, like I mentioned before. Whereas I don't think you get that as much as you used to in bigger practices. And I will say, like in the hospital setting, back when I started 22 years ago, your family practice physicians rounded on you. Your doctors came to the hospital, and that's changed to a huge degree now. Not saying that some still don't, but especially in rural areas, I believe they do. But the hospitalist mentality came along probably 10 or 12 years ago, which, not bashing that at all, that's a great thing too. So the hospitalists or physicians that stay within the hospital setting don't have their own practices, but just take care of whoever's patients are in the hospital. But again, in the community setting, our physicians still go to the hospital. They still round on you, whereas that I think is rare for a lot of the specialties now.
Yeah, I think just, in the 10 plus years that I've been working for COA, I've seen a lot of changes, and there's so many demands, on the professions. Doctors used to be able just to take care of the patient. That was their role. But now they have to be involved in so many other issues, a lot of those issues that COA addresses. Right. And I do think that another reality, even though it's uncomfortable to talk about it, it really is, but we'll still talk about it, is burnout. How do clinicians avoid burnout? Like, it sounds like you have a really strong team, but what other things, locally or nationally, are you seeing burnout? And, some of the other big oncology topics that are related to nursing that have happened in the last year is, telemedicine. We know how that changed for the physician. I'd like to get insight on how that impacted nurses. Did nurses, I know some of the nurses played a role in that. We'll start with that. Those two topics, like kind of burnout, and then some of these changes that put more pressure that maybe led to burnout, was like telemedicine. Talk a little bit about that.
Sure. I mean, let's go ahead and throw the word COVID in there too, because that has been a big part of burnout. I think even in our setting, I see more burnout in the hospital settings of the nurses that have been working on the floors through all this, and we have had some new nurses come to our practice recently. We are growing and expanding right now and adding a couple more physicians in the fall, so we're building our team. So we've had some nurses that want to leave that big hospital setting and come to a more personalized setting. And I think a lot of that is due to their burnout on that level. And they know they can be a part of a team where they really know their patients, and it's not different patients every day you go to work, that type of thing. So I think that's helped with that. I want to throw in about COVID. I'm kind of a little bit of a curveball from what you were saying, but I think one thing we've seen that's given us some burnout with COVID is, we had to stop any family members or anyone coming into treatment with you. So you can imagine, again, being a patient, having to go to your first treatment by yourself. You couldn't have anybody in there with you, and people were so scared of just the unknown. And I think we were able to help with that as far as being the personable nurses that we are. Thankfully, right now we're at the point you can have one person in there with you that has to, of course, stay masked and socially distanced and all that as well. But I can't imagine, so we saw the stress of that. We saw the worry in their eyes, the fear of being in there alone the first time, not knowing what was going on. And then if you had a reaction, it's even worse because no one is there with you that you know. Another thing too, we saw a lot of is people just delaying appointments, just not like we've talked about time to screen. We saw a lot of people not get screened, but we even saw people that wouldn't come in for treatment that needed to be treated. So I think a lot of that causes burnout in the whole COVID effect overall. I'm off subject a little bit from where you were, but I just want to get that in there in time.
No, Brenda, I'm really glad that you mentioned that, because I think that we all have a tendency to just want to be done with COVID and pretend it's over and not another conversation or webinar on COVID. But that's just not the reality. We were all super excited. I will admit, like when the lockdown in Connecticut was lifted, I cannot wait to say goodbye to my mask and just get out there and like hug people. Well, I tried to hug people just on autopilot, and then I was like, oh gosh, this is a new world, Rose. Don't try to hug people. But no, now we're dealing with the Delta variant, and we're seeing again the horrifying daily rate of COVID diagnoses, and I cannot even begin to imagine the stress and pressure that puts on nurses. So, really, and I mean it from the bottom of my heart, and I know that I am not alone. Like what you are literally doing, working in that environment with the most vulnerable patients. And Brenda, like I see your heart, like you choked up, and that's a very natural reaction.
Yeah.
I cannot imagine how gut-wrenching it would have been if I had to go to my first appointment without my husband.
Right.
Because I was I was not strong. I was super private. I kept it to myself. I've shared this before. But just his presence there, I wasn't talking, which is a shock to people because I love to talk. But, to go in there, that is so sad. And to know that they can have a nurse and that you feel that, you get it. That shows that that you have not become desensitized. And I think that's so important. That's why I think the nursing role is so incredibly valuable. And it's so important because it would be easy to get desensitized. It really would, because, here's another cancer patient. But like I had, my main chemo nurse, I had one chemo nurse. I had, Lynn Matoro, who I adore. Yeah. I had one oncologist, Dr. Jonathan Paul. Now, they had thousands of patients literally over their career, thousands, right. But they were the only doctor and oncology nurse that I had. So that's the role you play. So, Brenda, thank you so much for having that heart and, helping us understand a little bit more about what you do. Is there anything that I haven't, asked you that you would like to talk about? Because I still have more questions for you.
Oh my goodness. I don't know. Go ahead with your questions.
Okay, well, I want to start with, professional development. I know that there is organizations like the Oncology Nursing Society who does fantastic work. I know several of the nurses from there. Is that something that you're personally engaged with ONS or any professional societies? What do you do outside of your nursing role that kind of keeps you on the front lines of what's going on, in addition to your work with PO and CPAN? What are your thoughts on that?
Sure. I'm involved in ONS on the local level. We have a Georgia chapter here in Augusta. So I would say the majority, if not all of our nurses are involved in ONS on the state level. We have had some of our nurses as well on the national level, attend some of the national conferences and go to DC and that type of thing. So we're very involved in the Augusta area, and especially with Augusta Oncology, we're involved in that. Of course, COA and CPAN, like you mentioned, and otherwise, that's really the only things locally that I'm involved as far as oncology goes and nursing goes. Of course, we're excited to get our support group going again when we can ever get through all of this and be able to do that live. We had a very strong live support group before COVID hit us. So hopefully we'll get that up and running again one day.
Yeah, and one of my favorite experiences, as I've shared many times, is I really love going out to the cancer centers, and I've been to many cancer centers across the United States. So I've been able to visit your practice, which is really incredible. And I love that river walk too. Was that really river walk? That was really nice. And it's just really special, seeing the connection and the support group that Brenda mentioned. I've had the opportunity to be there with this great group doing a CPAN event, and they just have, your patients are so engaged. So I think that speaks volumes, because cancer patients really do love their cancer center. And when I say love, I mean they literally love it. So thank you, Brenda, so much for being with us. And I've seen a couple of chats coming through, and I'm just going to ask our tech team behind the scenes, who's actually one person, Drew Lovejoy, did a great job. And maybe you can screenshot some of those and we can address those later. And I want to spend some time, Brenda, before we move on, I want to spend some time asking you about some of the fun stuff you do, but do you want to wait till we show a picture first?
Okay.
Okay, why don't we go ahead and go to the next slide, please? Okay, Brenda, so it's good to know that you're not just working all the time. So can you tell us about, and this makes me smile, that nurses, you have these super intense jobs, but hopefully nurses are doing what you're doing. Tell us a little bit about some of these pictures.
Yeah, so a couple of these are from, actually, like 3 or 4 of them are from local walks we've done here for different organizations or different individuals even that have hosted walks for cancer. And of course, the bottom left was when we did a COA presentation there with Dr. Atkins, one of our physicians here on staff. Kind of towards the bottom right corner actually is one of our patients when she rang the bell. And I do want to throw in real quickly too, talking about our nurses here and how they have to think and adjust sometimes to different things. We had a bell on the wall, you can see in that picture, that was attached to the wall. Well, once COVID hit, you couldn't have families come back there to celebrate with you when you ring the bell for end of treatment. So our nurses were creative enough to take that bell down and put it on a pole, on a rolling IV pole. So we now have bell parties in the parking lot, so they can do whoever they want. And it's a lot of fun. So I just, shout out to them for thinking that through and coming up with a way for people to still be able to celebrate with those they love. There's another picture there of us dressed up at Halloween and different things. Of course, I want to call attention to the top right corner, which are my 4 babies, my puppies.
Oh, so. Do they have names? That was a dog reference I told you people about earlier. Yeah. They always have dogs. They always have the babies in their mind.
Yeah, so the 3 yellows are not related, although they look like they are. I just have a yellow dog addiction, apparently. So
you collect them, but that means you love them.
Yellow dogs, yeah. Some people collect shoes, I collect dogs. So we've got Oakley in the front, and then Starling to the left, and then River kind of in the back there. He's my only boy. And then the little princess in the back left corner is Nikki. She is the boss.
She is a princess. Why does she get like the special bed and no one else?
Because she's a brat. she's the 25-pound boss of all the big guys. Wow. And I do a lot too. I'd say, as far as talking about things to do on the side, I do work with a rescue. I don't know if I can mention the name or not on here, but it is a nonprofit rescue. It's called Project Freedom Ride. And it actually was started by a little boy who's now 10. He started when he was 4, trying to save dogs, and they've saved over 3,600 dogs in the last 6 years. Wow, I can throw a little plug in there. You can look up them on Facebook, but I do volunteer directly with them, and we go into the shelters and do a lot of different events and things. So that is a huge way for me to clear my mind of work sometimes on the weekend, to go help other dogs. So
that's really special. And having dogs is way better than having all the shoes. Like I have so many shoes that if I got more than last year, no. But if I had a dog, I would be out walking my dog. So right. You shared so much today. Thank you. And I just want to also say something. Because we're COA, we represent community oncologists. We represent community oncology. That is what we advocate for a multitude of reasons. But, as Brenda mentioned earlier, a lot of our physicians also work in the hospital setting as well. So we also have tremendous respect for all of our colleagues in the hospital setting and all of the incredible nurses and doctors there as well. We do know that there's differences in care. That's well documented. But I absolutely know that, that the heart of a nurse, there's great nurses in all settings. And I know because I've had many of them. So, thank you so much, Brenda, for sharing and giving us a window into what you do and what a lot of other nurses in your various roles do. I know that you are greatly appreciated. And I'm the type of person that likes to tell people what I think of them. And, I think out loud a lot of times. But I know that there's so many patients that have probably wanted to thank you and thought you were all so incredible and never did. But for all those patients that thanked you, I just want the nurses to know there's 1,000 other patients that thought you were really incredible too. Next slide, please. Thank you, Brenda. Or next slide, Drew, please. So thank you, Brenda, and thank you to all of our participants today. Oh, and an extra special thank you. I know that a lot of you send me notes saying, Rose, I got this, I got the invitation and I shared this, with my professional groups or with my colleagues. And really remember, that's a big part of advocacy is we want to spread the news and share the learning opportunities and be lifelong learners together. And once again, you're going to get to meet my colleague, or you know him already, Nicholas Ferreros, who's our Director of Communications. He's going to be back with us in September. And I say back with us because one of our advocacy chats, we talked about our Time to Screen campaign. And if you've been picking up your local news, your national news, the Time to Screen campaign is all over the news. We have a celebrity spokesperson, Patty LaBelle. So Nick is going to give you a bunch of updates on that. And most importantly, we're going to leave you with resources. And maybe you could be one of the people we interview in your local community about Time to Screen. Thank you for being with us today. Enjoy the rest of your day, and I'll see you next month.